This video displays the technique of laparoscopic Heller's esophagocardiomyotomy for Achalasia cardia. The patient was a 4-month-old child with recurrent vomiting and failure to thrive, and an esophagogram showed a dilated esophagus with hyperperistaltic waves and narrowing at the lower end. The child has been positioned supine on the operating table, lying transversely with the surgeon standing at the foot end, and a 5-port technique is used with the 2 operating ports near the xiphisternum, the optical port just above the umbilicus, a liver retractor inserted through the right lumbar region, and a gastroesophageal junction grasper through the left lumbar region. We were using a 5 millimeter 0-degree telescope for the operation. The table has been tilted towards the foot end of the patient to make the intestines drop away from the upper abdomen. We were using a fan-shaped liver retractor for retracting the right lobe of the liver. Upon entering the abdomen, the first step is to try and visualize the gastroesophageal junction, and this is covered by the phrenoesophageal ligament. The gastroesophageal junction is grasped near the caudate lobe of the liver and retracted downwards and to the left side. This puts the phrenoesophageal ligament on stretch and makes it easy for the junction to be visualized. Two operating ports were inserted, one of which transmits a Maryland grasper and the other one transmits the harmonic scalpel probe. It is not necessary to use the harmonic scalpel in these patients. However, it makes a nice instrument if it is available. We are now dividing the peritoneum over the caudate lobe of liver to delineate the phrenoesophageal membrane and begin the exposure of the esophagus. Quite often, due to the periesophagitis in this region, there are a lot of blood vessels and thick connective tissue, which needs to be carefully dissected away before the esophagus can be visualized. The caudate lobe is a good landmark to the right crus of the diaphragm, which can just be seen there in the curve of the caudate lobe. As you can see, there is a prominent artery sitting just at the site of dissection, and needless to say, injury to this needs to be carefully avoided. Another important structure which is very near the plane of dissection is the inferior vena cava, and care must be taken that during the exposure of the right crus of diaphragm, we do not inadvertently stray into inferior vena cava territory. One can easily make out the degree of periesophagitis and neovascularity near the lower end of esophagus, and matters are not helped somewhat by an overtly large caudate lobe. However, with a little persistence, the right crus of the diaphragm is clearly delineated, and this is the most important landmark for dissection of the esophagus itself. Now here we can see that an opening has been made in the peritoneum which overlies the esophagus and then continues to overlie the right crus of the diaphragm. It is recommended that the peritoneum over the right crus should not be dissected completely off it, as later when sutures are applied to narrow down the crus, the presence of peritoneum prevents the sutures from shredding the muscular fibers apart. This sounds good in practice, however, it may not always be possible if the degree of periesophagitis in this region is very high. Using the opening in the peritoneum as a guide, we are now proceeding to dissect behind the esophagus. And it is well apparent that it is densely adherent to the surrounding structures, and also the appearance of the esophageal muscle itself is inflamed. Due to periesophagitis, the amount of bleeding encountered is also more than normal. However, as seen here, a clear plane can be established behind the esophagus to reach to the other side for completing the circumferential esophageal dissection. It is now becoming apparent that the esophagus is beginning to narrow a little way outside the diaphragmatic crus, and a little further mobilization into the lower mediastinum is needed so that the esophagomyotomy can be performed comfortably. The blood-stained fluid pooling around the spleen is suctioned away, and we then return to the dissection at hand. After the delineation of the right side of the esophagus, it is now time to expose the left crus of the diaphragm and the left side of the esophagus. And again, using a combination of blunt and sharp dissection, the left crus is clearly delineated in the depth of that wound and the left side of the esophagus mobilized. We can see the fibers of the left crus and the clear plane between the muscle and the esophageal tube. This space has to be developed carefully so that a sling can be placed around the esophagus for lifting it up for the esophagomyotomy. We are now clearing away the last few remaining adhesions on the front of the esophagus so that all its circumference is clear and it can be lifted up. So now we can see that a reasonable length of the esophagus has been mobilized, and towards the mediastinum there are still clingy adhesions, but we can clearly see that the wide esophagus narrows down as it proceeds distally towards the gastroesophageal junction. These adhesions are being divided so as to provide an adequate window for when the fundus is going to be wrapped around the esophagus after the myotomy has been performed. Here we can see that a feeding tube has been used to pass a sling around the esophagus, and this will be used to hold the esophagus steady once the muscle is divided. The myotomy is commenced on the surface of the gastroesophageal junction as low down as possible. It is at this point that the muscle layers and the mucosa of the esophagus and stomach are separate from each other, and the muscle can be opened without damaging the underlying mucosa. Using blunt tipped scissors, an initial nick has been made and a plane is then being developed to carry the myotomy further cranially. Usually in the lowermost part, the muscle layer is thin, therefore care needs to be exercised. However, gently the muscle can be separated from the mucosa enough to allow it to be divided without injuring the mucosa. We have now proceeded a little further up on the esophagus, and you can see that the plane here between the muscle and the mucosa is much clearer, and therefore the myotomy progresses a little more rapidly. It's 7 o'clock. However, it is important not to get overconfident, as the inflamed and friable esophageal mucosa can very easily get damaged by an inadvertent nick of the scissors. Little by little, picking up the muscle edges as they are divided, the myotomy is progressed cranially. As we come on to the lower esophagus, the edema caused by the esophagitis and the adhesion of the mucosa to the muscle becomes apparent. So, even greater care has to be exercised while separating the muscle from the mucosa. Now, I'm not very sure whether it is actually advisable to use an energy source to do this, but in this area of the esophagus, the muscle is quite thick, the plane from the underlying mucosa quite well visualized, and therefore we have hazarded a few cuts using the harmonic scalpel. However, as we have seen before, the use of simple scissors is more than adequate for this purpose, and an energy source is really not required. As in the open operation for Heller's esophagocardiomyotomy, it is important to separate the muscle from the mucosa for nearly half the circumference of the esophagus, and then to put a fundoplication or a thal patch onto the lower esophagus for the prevention of reflux. As you can see, because of the periesophagitis, attempts to separate the mucosa from the muscle around the circumference sometimes lead to tearing of the muscle fibers. So I think we need to be judicious in as to how radical the separation of the mucosa and muscle should be. However, there is no compromise about the length of the myotomy on the esophagus, and it should start from below the gastroesophageal junction and go up at least 7 to 8 centimeters on the lower esophagus until the dilated portion is reached. And if you look at the extent of the myotomy here, we are now just a little way short of the diaphragmatic hiatus. And little by little, more than half of the esophageal circumference has also been separated from the mucosa. Having achieved a complete myotomy, it is now turned for us to mobilize the fundus of the stomach so that it can be brought round behind the esophagus to perform the Nissen's fundoplication. And as you can see, the fundus goes fairly loosely anterior to the esophagus, and we may or may not need to divide some of the short gastric vessels connecting it to the spleen for it to come round the back of the esophagus. Prior to the fundoplication, however, it is necessary to narrow down the esophageal hiatus, and this is what we are proceeding to do now. We can clearly see the esophageal hiatus and the extra dimension that it has got compared to the circumference of the esophagus, and 1 or 2 stitches will suffice to narrow that gap down. We are using a 2-0 silk suture on a needle for these stitches. Ethibond is unfortunately not available in our center. If you look carefully there, you will notice that some of the fibers of the right crus of the diaphragm have actually sheared away because when the knot of the suture was tightened. And this is the reason why it is advisable to keep the peritoneal covering of the right crus intact, so that once the suture is being put in to narrow down the esophageal hiatus, the fibers don't tear away. Having narrowed down the hiatus, it is now time for the anterior thal patch, and the fundus of the stomach, as we can see, is lying very loosely. So the first suture has been taken in the esophageal hiatus itself, and it is being used to anchor the tip of the fundus in position before the right and left border sutures are inserted. So there we see the first knot getting snuck down, which anchors the tip of the fundus to the diaphragmatic hiatus. We are now putting the stitch between the right esophageal margin and the right border of the fundus of stomach. I think one suture is going to suffice on either side because we have not injured the esophageal mucosa, and therefore a watertight seal of the patch onto the divided esophageal muscle is really not required. So we have secured the right border of the esophagus to the right border of the gastric fundus. And now to repeat the same on the left border, taking the suture in the gastric fundus first as it is lying uppermost in our field, and picking up the edge of muscle of the esophagus where it is important to get a reasonably thick bite. At the end of the operation, we are just evacuating the accumulated blood-stained fluid in the left hypochondrium, and closure of the ports was done by single sutures of 3,0-polygalactin. Post-operatively, the patient was allowed oral feeds on the next day and discharged on the fifth day. He is doing well at follow-up of 3 months.